Hi there, my name's Natasha Lieghl from the Princess Margaret Cancer Center, and I'm delighted to talk about the evolving landscape of oncogenic drivers in lung cancer. These are my disclosures. At a very high level, I'm going to go over some of the more recent targets and therapies beyond EGFR, ALK, ROS1, and BRAF, highlight some of the practical challenges in implementing precision medicine in the clinic, and talk about a few selected future strategies. I'm going to start with a case. This is a 62-year-old lady that I met last year during the pandemic. She's a Caucasian, never smoker, and was being investigated for recurrent pneumonias that didn't clear. She had a family history of breast and kidney cancer, and when she was finally diagnosed, had widespread disease, had a biopsy to rule out breast cancer, is what the outside pathologist was told to do, and he diagnosed adenocarcinoma from the lung, but interestingly also did breast markers, including HER2, and showed HER2 positive expression. Clearly for lung cancer, we need to know more, PD-L1, and a growing list of genomic targets with changing questions of which targets to test, which tests to use, and when to introduce testing. Current recommendations are rapidly growing. On the left, you can see that the NCCN currently recommends at least 8 genomic targets, as well as PD-L1. The other organizations are also moving up to that, and I think it's really just a reflection of how recently they've updated their guidelines. ESMO currently recommends NGS testing for all advanced adenocarcinoma patients. And of course, this is moving even to earlier stage, for example, with EGFR testing in patients with resected lung cancer for adjuvant TKI therapy, as well as PD-L1. I think it's so important to remember that complete biomarker testing does not stop with PD-L1, but also importantly, genomic data. We know that a quarter of our patients with genomic targets have high PD-L1 expression and are candidates for targeted therapy, which will outperform chemoimmunotherapy or immunotherapy alone. But unfortunately, not all patients can access NGS. There's a nice paper, as you know, many of you are authors and collaborators on this, talking about or illustrating that certainly in India, patients that access genomic testing because of funding reasons will often access a variety of tests, most commonly immunohistochemistry and PCR-based testing, and that NGS is uncommon. However, if it can be offered routinely, the results, I think, will surprise you. We put together a project last year where we actually had an industry-funded reflex NGS testing program just to see how valuable it was, and we actually found targetable alterations in half of our patients with lung adenocarcinoma. Some of the barriers, of course, cost, quality of both assays, lab experience, and tissue, the fact that tissue testing is not centralized, and the fact that those people who make the diagnosis of lung cancer often don't know which molecular tests are required. Turnaround time and sufficiency of tissue are, of course, also major barriers, particularly in Europe and US and Canada. But clearly we need to keep pace with the very exciting explosion in targeted therapy options. And we can see for the 8 recommended biomarkers here, there are targeted therapies now approved, at least in the US and growing around the world for each of these genomic subgroups. When you look at the placement of these, all of these have been approved based on single-arm, non-randomized trials. Many of these in the US are approved first line, usually if they have response rates above 60%. Poziotinib is a little bit lower at 43%. Many of these drugs, for example, targeting TRAC, RET, and MET, have very impressive intracranial activity. But drugs developed in the second line with lower response rates as single agents, sotorasib, amivantamab, mobocertinib, as you can see here, these really require platinum retreatment. One of the questions always is, when patients have oncogene addiction or have an oncogenic driver identified, how helpful is immunotherapy as part of their treatment paradigm? And I think, as you can see on the right, for many of these patients with oncogenic targets, immunotherapy is a very limited benefit. And perhaps the exceptions to this are patients with KRAS G12C or other KRAS alterations, and those with MET, exon 14 skip mutations, and perhaps other MET alterations. We're learning also that co-alterations may be relevant. They're probably not relevant for practice just yet, but we've learned a lot about potential negative prognostic associations with STK11 and KEAP1 alterations concurrent with KRAS. There have been some exciting data looking at sotorasib on the left and adagrasib on the right, suggesting that in patients with STK11 co-mutations, perhaps the G12C inhibitor may lead to better outcomes. And perhaps this is a strategy to get to first line or in combination with other agents. So what about our patient? Well, she did have genotyping. She had a hotspot panel, so not broad spectrum NGS, and she was found to have an exon 20 insertion mutation. Also, she had a liquid biopsy, again, a very limited DNA hotspot panel, and was found to have a MET variant with a high variant allelic fraction, 53%. And in the fine print at the bottom, the report talks about the possibility of a germline variant. And she had PD-L1 negative disease, as you might expect. So are they both actionable? Which one should we treat? Should we go for the higher VAF or the one that we better understand in lung cancer? Does she need further testing? What should we do about this comment about the germline? Lots of questions for a Monday morning in clinic. So, there are a number of resources that you can use in clinic that are very helpful. Sometimes they'll be on the report with very excellent annotation, but sometimes I'll turn to OncoKB or other sources to see that she has a classic exon 20 insertion mutation, which is actionable, and that her MET alteration certainly confers sensitivity to MET inhibitors, but it's not a MET exon 14 skip alteration, and there is some concern about the level of evidence supporting targeted therapy. So the current standard, of course, is platinum-based chemotherapy. PD-1 inhibitors should not be used as single agents in the first-line setting, and the NCCN also cautions that if you use chemoimmunotherapy, you do need to be mindful of subsequent toxicity later. They mentioned pneumonitis, but we've also learned that hepatitis is potentially very important. We have two exciting new drugs, amivantamab, which is intravenous, a nice response rate of 40%, duration of response of about 11 months, but a very intensive intravenous schedule, weekly to start for a month and then every 2 weeks. And also mobocertinib, easier for patients, oral, is associated with significant diarrhea, 28% response rate, but the potential for response may be prolonged. The median duration of response in the data reported so far, 17.5 months. We've also learned that NGS testing is important. On the right, in the bottom right, you can see that common PCR-based assays only detect about half of the potential exon 20 insertions that lung cancer patients have. And so potentially we're missing half the patients with PCR. Now, what about her HER2 expression? And I think it's so important to recall that HER2 is different in different cancers. So in breast cancer and gastric cancer, HER2 amplification is quite common. We do see it in lung cancer, about 3%. We also see HER2 expression. We see it perhaps more commonly after EGFR kinase inhibitor resistance. But what we're really interested in are patients with exon 20 insertion mutations. We see those in about 2 to 4% of cases, never smokers, women, patients of Asian background. And in particular, it's the YVMA insertions that you can see on the right that are the most common. A small number of patients have mutations in the transmembrane domain, and those are classically associated with response to kinase inhibitors like afatinib. It's also important to remember that just because one of these markers is positive does not mean that the others will be, and there's only about 10% of overlap between ERB2 amplification and exon 20 insertion mutations. A very nice publication in the New England Journal recently from Dr. Bob Lee and colleagues, looking at the Trastuzumab Deruxtecan antibody drug conjugate. This is also, of course, approved and well known to you in breast cancer, but in lung cancer, they use a slightly higher dose, 6.4 milligrams per kilogram instead of 5.4. Very nice response rate, 55%. Nice median duration of response, 9.3 months, and progression-free survival as well. The challenge, of course, really related to the Deruxtecan moiety and perhaps the dose is the number of patients that stop for toxicity. 1 in 4, a third had dose reductions, a quarter had interstitial lung disease or pneumonitis related to drug, a few of them fatal, and while half of patients recovered with steroids, the other half have not yet. And you can see here on the right a very nice waterfall plot that really does seem to track with the insertion mutation, and whether or not HER2 protein is expressed or whether or not it's amplified seems less relevant. There's also activity in patients with CNS disease and with prior HER2 therapy. So this is a highly promising agent, but is it too toxic first line in our patients with lung cancer? Should we be looking at the breast cancer dose, 5.4 milligrams per kilogram? Those studies are ongoing. And is 55% enough for first line without a randomized trial, or do we need to add a drug like platinum? I think it's also important to remember in clinic that IHC testing, like our patient had, is not the same as mutation testing. When we look at just IHC expression, the response rates are much lower and in fact aren't controlled for the possibility that this low number of patients who did respond may well actually also have HER2 insertion mutations. So important to remember that for drugs like this, it's really the mutation that you want to watch for. There are also some nice data presented at ESMO looking at Poziotinib. This drug does have toxicity, response rate's a little bit lower at 44%, but still excellent. Median duration of response, 5 months, but it is an oral agent. Does have significant toxicity, including diarrhea, rash, and stomatitis, but these are reversible, and exploration of BID dosing is ongoing. So my patient came to me and said she was not interested in platinum doublet therapy, which would have been the first line standard. And so we put her on a clinical trial. She's actually had a very nice response, as you can see on the right. We did go back at the time. We didn't wait for repeating tissue testing, but we did do MET testing in tissue because we thought that the alteration in blood with such a high VAF would be a normal variant in her germline. Or sorry, not a normal variant, but a variant in her germline. And we also went back to look at ERBB2 testing, and this was negative. We then sent her to the genetics clinic, and I think this really highlights the importance of molecular tumor boards, the ability to access genetics expertise. You know, certainly if you're practicing in isolation or you don't have a group with an organized tumor board, there are things like the Foundation Medicine Tumor Board or other tumor boards that you can join. I know Sloan Kettering has a tumor board that you can join. Also, David Gandera and the IASLC have tumor boards that you can join. But again, it's so important that no matter which one you join, you do have access so that you can review your challenging cases. And these are some of the resources that I use to help me determine what the clinical relevance is for my patient. In particular, OncoKB is one of my go-to databases now. And also when you think about when should you be concerned about germline alterations, you know, usually there's a very nice paper from the ESMO Precision Medicine Working Group, but usually, you know, you don't need to worry about this until you start to see sort of variant fractions or more than 30% in terms of single nucleotide variants, or more than 20% for small insertions and deletions. Although again, you know, if you have a very highly cellular sample, that might be related to cellularity as well. So what about resistance? And, you know, it's been interesting across the genomic subtypes and across the different targeted therapies, the pattern of resistance is very similar. You have on-target mutations, so an alteration within the drug target. You have bypass signaling or emergent amplification, commonly met across many of these groups, or other fusions. Mutations in downstream effectors, for example, MEK, RAS, or others. And histologic transformation or lineage plasticity, small cells seen now beyond EGFR and ALK and ROS1, and also a transformation to squamous and other subtypes. And, you know, there are a lot of data out there. I'm just going to give you a few examples. You know, already gatekeeper mutations and solvent front mutations. Gatekeeper mutations, of course, very relevant to ATP binding, and solvent front really relevant to the steric hindrance that's presented to drugs. But you can see here on the left with Larotrectinib, they've identified solvent front mutations that can be overcome by newer agents, Selatrectinib, Repotrectinib. And on the right for RET, again, both solvent front and gatekeeper alterations that can be overcome by both emerging and existing drugs, Cabozantinib, Vandetanib, Ponatinib, and more. But it won't be easy for all of our targets and targeted therapies. For example, with KRAS G12C inhibitors, because it's not a receptor tyrosine kinase inhibitor, rather it binds to GDP bound or inactive KRAS, we really don't necessarily have the same mechanisms of resistance. Interestingly, they can be classified that way. So acquired alterations in KRAS, other bypass signaling. We've seen acquired gene fusions in colon cancer, although not lung cancer, although it is small numbers. But in particular, you can see the emergence of escape through different signaling pathways, upstream ability to evade this conversion to drug-bound inactivated GDP-bound RAS. And of course, things like concomitant alterations, the immune microenvironment, and allelic frequency, as well as KRAS dependency. Is it a clonal event or a subclonal event? So does it drive the cancer or is it more of a passenger? I think are all going to be important. Now, clearly, we have so much trouble getting our patients biopsied in the first place and getting testing on tissue that this is going to be very challenging on an ongoing basis. And so liquid biopsies have really emerged as a potential solution. Certainly in the first line setting, whether we use it sequentially, if insufficient tissue at the same time, or use plasma first, this has really become a robust and acceptable way to detect alterations. We recently did a study in Canada where we looked at testing patients both with tissue and blood, and we found on the left that more patients were able to access targeted therapy when we combined these. Patients had similar outcomes, whether we found the target in tissue or in plasma. And in the Canadian system, which is of course a relatively high resource system, we actually saved money, because immunotherapy, which doesn't work in these patients, is more expensive than targeted therapy. So we were able to get more patients to more effective, less expensive treatment. Plasma testing was also faster and rescued more patients. And what about monitoring? And so you can see over time, clonal evolution and different changes. And certainly the temptation in oncology is always to add more drugs and to add more targeted therapies. But could it be that we could also de-escalate if a patient has had 1 year of checkpoint inhibitor maintenance therapy? Could we check ctDNA levels to discontinue something, or could we add chemotherapy or radiotherapy, not just targeted therapy? And I think this is certainly going to be an important way forward, and we're going to need trials to demonstrate clinical utility. So to conclude, in 2022, I think we've never seen a faster pace of evolution of precision medicine in lung cancer. That balancing act in both low and middle income, and I must say even in high income countries, continues to be a struggle as we try to achieve best practice, for example, reflex NGS testing and access to targeted therapy for all patients versus best possible practice. Obviously, you're not going to ask a patient to spend money on NGS if you know they can't afford targeted therapies or you can't get them, and cost is always a challenge. I think, though, it will get more challenging. So we do need to find ways to overcome our issues with access. There's going to be more precision and more profiling in our future, whether it's identifying better targets for existing therapies, such as co-mutations, antibody drug conjugates, more targets, for example, in PARP, ATR, and others, and moving earlier in the course of disease. Finally, I think that we will see more plasma NGS-guided treatment decision-making, particularly in the targeted therapy realm. And so we see a lot of progress ahead. And with that, I want to say thank you so much.